Ji, Bismillahirrahmanirrahim. Dear friends, colleagues, juniors, Assalamu alaikum. Thank you very much for joining. Once again, this on this Sunday we are here, and this time the topic is ERCP, and we are very grateful to Dr. Waqar Khan from Manchester that he's going to guide us on ERCP accessories. I'm sure you all understand that a procedure is not complete unless you have chosen the right kind of accessories, and choosing the right kind of accessories for a given procedure, you have to plan ahead. And in order to do that, Waqar is going to highlight the um, various kind of accessories from basic to the advanced and from minimum to the optimal. And let me tell you that unless you have planned the procedure beforehand, you'll not be able to perform good, you'll not be able to deliver good service to the patients. And in this context, today's presentation is going to be very, very important to understand the various aspects of ERCP. I'm really thankful to College of Physician Surgeons, to Dow University Health Sciences, King Edward Medical University, University of Health Sciences, Digestive Disease Foundation, and Pakistan Society of Gastroenterology for providing us the platform uh, to impart this important information for all of our colleagues. We all learn with this, and I'm thankful to my colleague Dr. Saad Niaz for co-hosting this session. I'm really thankful to Dr. Waqar Khan for agreeing to deliver this talk on an important topic like this. And all yours, Waqar, please start.
Right. Assalamu alaikum. Thank you very much, Gayas and Sadnias, for kindly asking me to speak on this topic. ERCP accessories, as you rightly mentioned, is a very important topic, especially for those who are about to start the practice of ERCP. ERCP, as you all know, has been introduced to this world in 1968, and it is now established as an important therapeutic procedure. In the past, it used to be a diagnostic procedure, and now it's mainly done with therapeutic intent. So it is extremely important that we choose the right sort of equipment and use it, put it to the right use, because ERCP is a procedure with a high risk of complication if not practiced properly. Um, I have been performing ERCPs on a fairly regular basis since 1989. So that makes my experience to be just over a modest level of 31 years. Um, there's a very wide variety of options there, but today I've chosen the ones that I have been using in my practice. And I'm sure some of you would disagree with it, but that's the whole beauty of our practice. So for any ERCP department to be successful, you need a group of well-trained, experienced endoscopists. Normally, it is advisable not to have just one person doing ERCPs. To maintain the service, it's always good to have a team of ERCPists. Again, you need a team of dedicated nurses and technicians who would support your service because this is a therapeutic procedure with a higher risk potential, and you need a team who communicate well amongst themselves, who know exactly what they are doing, and in fact, you need technicians who can anticipate your next move. So, and most important, indeed, last but not the least, you need the right equipment. And that's what we are going to talk about. So all endoscopists need to be aware of the indications, the unique features and safety aspect of the various accessories. You should be familiar with your equipment usage, and you should have different available types with you. Um, One should also be aware of the limitations and complication potential of your various instruments. Like, for example, if you are using the guide wire, you should know that you should use it judiciously so that you do not puncture the liver or any other organ. If you are using the sphincterotomes, you should make sure that your sphincterotomy is of a level where it doesn't cause perforation. And if you are using the baskets, you must ensure that you do not cause trauma to the vital tissues. Because remember, one tends to get carried away when you are taking big stones out, but always remember you are performing it on a live patient. Now, there's a whole array of instruments that is available to you. There's more toys than you can play with. So just to, I'm trying to see if I can adjust the screen. Right. So you can see an array of which includes synchrotomes, guide wires, stents, guiding catheters, uh, cannulas, balloons, everything, stone extracting baskets, uh, and again another array of instruments and accessories with more stress on the baskets and stents and grasping forceps. So there's quite a lot to choose between those, and really uh, you need to know exactly what instrument you need to use for that particular occasion, for that particular patient. And sometimes uh, you might be surprised, and you may have an emergency and you might need an equipment which is not something which you planned for. So you should have all those things in reserve as well, the ones that might come handy in emergency. So that's why it's always good to have a well-stocked department. Now, to start off with, the ERCP is always, as you know, most of the time carried out with a special side viewing duodenoscope or an ERCP scope. And the important thing about ERCP scope is that it is a side viewing scope. The reason for that is that your papilla is located on the lateral, duodenal wall, which you cannot visualize very well with the front viewing scope. So when you are using a side viewing scope, you can see it, as they say in French, en face, which is face on. So um, you need a special scope for that. One has to be trained in the use of an ERCP scope. And I always tell my trainees that they should consider using an ERCP scope as if they are driving a car watching out through the side window, which is always a bit different than driving, watching through your windscreen in the front. Fortunately, it has a large working channel of about diameter of 4.2 millimeters in the therapeutic scope, which is useful for using large accessories and using multiple accessories at any one time. Uh, that makes the ERCP scope thicker as well. So obviously when you are using a bigger scope, there's more risk of causing trauma. Now, the P's, I always tell people, the P's of ERCP. The first important one is position, position, position. You always need to be in an optimal, ideal position before you can even think of cannulating. So trying to cannulate from an awkward position is always a waste of time. So always ensure that you are in the right position to cannulate. The other thing is precision, because it's a very delicate procedure. When you got your position, then you further need to adjust your precise point of entry. And that is an art. It is quite a fine art. And obviously, unless and until you've got your position right, you cannot make the right adjustments. And all these you do to achieve perfection. And I can assure you that after 30 years of practice of ERCP, I've not achieved perfection. Some of my colleagues in the audience already might have it, but I'm sorry to say that I've not achieved that as yet. And I'm still trying to do that, though I'm running out of time. So it is most important. In fact, one of my colleagues who was working with me is quite a senior endoscopist, and he came and asked me to show him, because I use the wire guided cannulation. I stick the guide wire out of the cannula before I cannulate the papilla. And he said, oh, this is a very neat way to do it, and can you show me? And when I was showing him, the problem was not in the guide wire, the problem was in his position. And I said to him that he should pay attention to basic things like getting his position right, and only then he can expect to use fine tuning, like using the wire first or the cannula first. That doesn't make much of a difference, but the position is most important. Just a close-up view of the tip of the ERCP scope. I'll see if I can use the pointer. You can see there's the elevator there, and that's the sort of the wire or the cable which brings the elevator up and down. The whole purpose of this elevator is the precision. You can move the cannula up and down with this elevator, so that you can, get the cannula into the ideal position. Now, again, I seem to lose that. The other important thing to remember is when we are still on the scope, that this cable comes through a special channel. And we have found, in fact, when I was a registrar in our unit, we had an outbreak of a Pseudomonas infection in patients who underwent ERCPs. And after a lot of searching and researching, we found out that the bacteria was stuck in the cable channel or the bridge channel of the Ercp scope. So that we reported that at the time in the journals. And now in some of the, especially in UK, we have a detachable cap here. For every time we do a procedure, a cap has to be attached on. I think it's in Pakistan and the US, it's not a detachable cap. It's just to ensure that the bridge channel is properly washed. This is the elevator in action. Now, regarding precision again and position, there are two options here. You can use the elevator to move your cannula, as well as you can use the handle of your sphincterotome or the cannula to move the cannula from down position to median position to an up position. So all these maneuvers are important to get your cannulation right. This is the top end of your scope, and that is the bridge lever, which you can move up and down, and those are the big wheel and the small wheel. And these are the locking devices. Right. In some special circumstances, front wing scopes are also used. I use them in cases of patients with altered anatomies. And most of the time we use standard gastroscopes, end wing gastroscopes, or in cases of Roux-en-Y patients, one may use an enteroscope. Nowadays, Olympus has come out with a special enteroscope dedicated for ERCP use. The only problem with that is, those scopes is that you have to have a certain level of skills to use those scopes. Otherwise, especially in patients with Roux-en-Y, if you are not careful, you might cause a tear of the stomach or the gastric remnant. So it depends on what method you use, whether you should use a laparoscopic assisted or EUS assisted ERCP in these patients, or a double balloon, use a double balloon device. So depending on your skill levels. Those are the patients who have undergone procedures like Whipple procedure, Roux-en-Y, or Bill.2 gastrectomies. And most of the time, you are looking for intubation of the afferent loop. Contrast agents are very important because those are the ones that you use to visualize the biliary tract. And there are different ways of categorizing them. There are ionic monomers, ionic dimers, non-ionic and monomer and non-ionic dimer. The bottom line is that the non-ionic contrast agents are preferred because of the lesser risk of side effects, especially pancreatitis and other allergic reaction. They can be high osmolality or low osmolality contrast media, and the low osmolality is preferred over the high osmolality because there is less potential for causing side effects or adverse reactions. Generally speaking, for image of strictures and pancreatic duct anatomy, full strength contrast gives a better quality image. For stone disease, I prefer to use dilute contrast. Usually I start my first injection with a half strength Omnipaque and then go on to full strength. Now the contrast agents are, sorry, I'm just trying to move the screen around. There is a risk of causing adverse reaction with the contrast agents as well. And if you are injecting too much contrast into the pancreatic duct, there's a risk of causing pancreatitis there. There is, because of the osmotic fluid shifts, low osmolality contrast is preferred generally. Now, there's a lot of issue about whether the patient is allergic to iodine or contrast agents in the past. Yes, one should be cautious. One should use prophylaxis. But generally speaking, the risk of contrast reaction in ERCP practice is very low because the rise in most of it is done in the contrast is injected into the biliary tree and does not, very little is absorbed systemically. The rise in serum iodine concentration with injection of contrast media during ERCP is about 1/100th of the intravenous administration. Likewise, it is even less than, it's 0.6% of that from coronary angiogram. So the potential for causing adverse reaction or anaphylactic reaction is very low, even in patients who are sensitive to IV contrast media. But in case there is a definite history of allergy to a contrast media, then we use prophylactic pre-medication with steroids and antihistaminic agent before the procedure and also after the procedure. In case you are not aware and you get a sudden reaction during the procedure, then in your department or in the ERCP suite, you should have antihistaminics and steroids available. Cannulation devices, that's where you start off with the real work. Standard ERCP cannulation catheters are made of Teflon, sort of plasticky material. They are available in different tip sizes and configuration, different lengths and number of available lumens, like they can be single lumen, double lumen, triple lumen, and they vary in their caliber as well. The diameter is usually 5 to 7 French, with the tips which taper down to 3 to 5. The tips can be straight, tapered, bullet shaped, globular, whatever, and they can take guide wires from 0.18 inch to 0.035. Right. Now, just a picture of some of the variety of ERCP cannulas available with a conical tip, bottle shape or bullet tip, filiform tip, and round tip. Some of them have a guide wire lockable device. Now, having said all that, they are very rarely used nowadays. I have not used a cannulation catheter or a cannula excuse me, for the last 20 years or so, because most of my cannulations I do with synchrotons. But I hear that there are still people who are obsessive about use of cannulation catheters before. So that's everyone's personal choice. But I think the general trend is that we tend to use synchrotons as our primary cannulation instrument. Synchrotons are basically designed for biliary sphincterotomy. It has a cannula. Nowadays, they all come in triple lumen, because that's the whole advantage of using a triple lumen synchrotome, is that you can have you can use a guide wire through it, you can inject contrast through it, and you can make a sphincterotomy with it. This triple lumen or the synchrotome, generally any type of synchrotome, are connected to a monopolar source of electric current, and usually the synchrotome has a cutting wire which is about 20 to 30 millimeters, which is used for cutting. The bigger the wire, the bigger your cut is going to be. I habitually tend to make generous sphincterotomies, so I usually like the one with the bigger wire. Now, a synchrotome usually has a retractable plunger or a handle, which you can adjust the tip, can bow it up or flatten it out. It gives the ability to flex the catheter upward and down. This is put to good advantage when you are making a cut with a synchrotome, because when you bow it up, the wire comes into contact with the papillary mucosa which you want to cut. In addition, it is also used to advantage when you are trying to cannulate the papilla. So it's very useful in fine-tuning your final approach to the papilla. And I think this is used to an advantage when we do it. There have been some studies head-to-head where they compared the cannulation rate of using a cannula as opposed to a sphincterotome, and there was a definite advantage of using a synchrotome, because the cannulation rate was from 84 to 97%, and with a cannula only, it was just under 70%. And this was using ERCP endoscopist of similar skills, or they were sort of using the same endoscopists were using the different catheters. So just a picture of what a sphincterotome looks like. I'm sure you are all familiar with it. That's the cutting wire. That's the tip beyond the wire, which can vary in length depending on your choice. And that's the guide wire. And that's the injection port for injecting contrast. The handle where you can move it up and down and change the angulation of your tip. And that's which connects the electrical port. Right, this is one of the Boston Scientific one that we tend to use, but not entirely my favorite. I only use it very occasionally. Some of my colleagues like to use it, but this is the one where we use the Dream Tome is the one that we tend to use with our with a short wire and with a locking device. Once you engage your guide wire in position and use it on a locking device, I'll show that to you later. You can strip the wire from the sphincterotome and take it out. This is the actual shot of the Dream Tone. If you see the cutting wire is fairly short on this one. I personally like a longer wire on here. The sphincterotome initially, when I was doing ERCPs in the early 90s, used to be single lumen. That meant that you could not use them over guide wire. So first you had to cannulate the patient with a cannula, take the cannula out. If they needed a sphincterotomy, you had to recannulate again without the benefit of the guide wire. And it used to be a real hassle because sometimes you couldn't get in the second time. So a big development was when we got wire-guided sphincterotomes, but still we couldn't inject any contrast in it. And then as the developments went, we came with the triple lumen, which was great because you could inject contrast through that and use a guide wire and do a sphincterotomy at the same time. Because initially when we got the wire-guided sphincterotome, the wires were not covered with Teflon, and you could not do a sphincterotomy over a wire. So once you gained access, you had to take the guide wire out to perform a sphincterotomy. But now we've got everything all in one. As I said, there are loads of instruments available. My favorite one is the one from Olympus, which is the Clever Cut. The advantage with the Clever Cut is that the cutting wire is quite long, about, I think, 30 millimeters. Half of the wire is covered with an insulated device, that's proximal half. And that is mainly to prevent damage to the overlying mucosa. So it's quite good. And ideally, when you are making a cut, the main cut is, well, this is the sort of features of the Clever Cut, because it got 30 millimeter cutting wire. Half of that is covered by, if you can I see with an eye of faith, with an insulating device. That one bit, the distal bit, is bare, and then you got a tip beyond the distal attachment of the wire, which is for cannulation. That's a guide wire. Now, this is the bit of the sphincterotome that you would use for cutting. You don't use the whole sphincterotome for cutting. So if you got the whole sphincterotome in the bile duct, you shouldn't be cutting that. You should have more than half of it out. So that again is a shot of the Clever Cut. So that's the insulating the material, and this is the part where you will be making your cut from. Nowadays we are using short wires, and we use the stripping Clever Cut type knives. So once we are in position, we just strip the wire down, and the sphincterotome comes out. Again, a close shot of the sphincterotome. So just to recap on the single lumen, the double lumen, and triple lumen devices for different, calibration, it went through an evolutionary process, and nowadays we just use the triple lumen. Now, sometime when you do your ERCP, the patient has got stone disease, you get down and you find one or two big diverticuli staring at you. And to make it worse for everyone, sometimes the papilla is stuck inside the diverticulum. that becomes a real challenge. And one can try and get into it with various maneuvers. It can be very difficult even in very skilled hands. We tend to use various options, and one of the things to do is to use one of the clips, and like one of the my favorite one for this reason is the Instinct Hemoclip, which is by Wilson Cook. They are much better. They are longer. They are adjustable, and you can stick them out of the scope, because some of the other ones, the original Olympus ones, are difficult to stick out. They cannot come out of the side wing scope, and even when they come out, it's difficult to deploy them. So I find the Instinct Hemoclip or the one by Boston Scientific, the resolution clip, quite helpful. Very little to choose between them. I can tend to use whichever comes to my hand. So that's another shot of the resolution clip. And what you do is you just grab a bit of the mucosa inside the diverticulum, and with one of the flanges, and with the other one you grab the mucosa outside the diverticulum and fire the clip, and that drags the the intention is to drag the papilla out of the diverticulum so that you can access it. The other option is by injecting some submucosal saline away from the papilla to bring it up towards yourself. Very similar to what you do in EMR. Various type of injection needle that you can use. The type of cuts that you do are the type of current that you would use. When you are doing a sphincterotomy, the ideal type of the current that you would use would be a cut current, because the cut current is very clean. The only problem with the cut current is that it can be, it's not very hemostatic, because it doesn't cause effective coagulation, it just causes a cut. So there's a greater risk of bleeding. If you use a purely coagulation current, it causes a lot of tissue damage, and it can cause complications like stricturing after sphincterotomy and more potential for causing pancreatitis. The ideal current that the compromise current that we tend to use, or a lot of people use, is the endocut or the autocut current, which is more of a blended, but it's more of a cutting current coming at various frequencies. So, and changing the type of current at a very high frequency rate. So that causes a low risk of bleeding, but gives you a very clean cut. Now, in patients who have got surgical altered anatomy, doing a sphincterotomy is always a challenge, because instead of making a sphincterotomy upwards towards 12 o'clock, you have to make a sphincterotomy cut more towards 6 o'clock. And your standard sphincterotomes are not sort of meant for that type of cut, because they would always go up. So there are various type of sphincterotomes designed, like the S-shaped, the curve types, the rotatable ones, which are all around there. I do not use any of those because I find them very fiddly. I've tried to use one or two of those, but they never work. I always find them very fiddly. So what I tend to do is, if I have to do anyone with altered anatomy, I would try and pass a small stent into the duct first, and then after achieving cannulation, to perform a sphincterotomy, I use a needle knife over the stent, and that I find is usually quite safe. Now, sometimes it's difficult to get a cannulation on the first go, and even in experienced hands, it might be very challenging to gain selective or to get selective cannulation of the common bile duct. If one is having problems, then there is an option of using a pre-cut to open up the papilla so that you can access the common bile duct directly. or even cause a sort of a colidoco-duodenal fistula by using a pre-cut. So the usual method of doing that is by using a needle knife and making a cut around the 12 o'clock position. Obviously, this should be done in experienced hands. I would not recommend this to some of the trainees or those who are just beginning independent practice of ERCP, because this is a freehand technique and there's a great potential to cause harm. So if you are not confident, don't do it. You should only do it under supervision, and once you are comfortable with it, then you should start doing it yourself. This is just a shot of packing of our one of the needle knives that we use. Usually use this one. It's got a 5 mm cutting needle, which is usually more than adequate. You don't need a very long needle because it can easily go through the whole thickness of the mucosa. Usually the good thing is whenever you make a successful cut, you can see the bile gushing out. And if you make a clean cut, you can usually see the common bile duct quite clearly. Just a view of the needle knife with the needle sticking out. When you are cutting the papilla with a needle knife, you always you bring the needle into contact with the papilla. Either you can make the cut upwards or you can make it from the body of the papilla downwards. So it depends on whatever you are comfortable with. They both achieve the same objective. Now there's another type of papillotome in which the sphincter, the wire is attached right to the end of the sphincterotome. It's called the Erlangen type papillotome, and it's mainly used for septotomy, especially if you gain access to pancreatic duct and you want to carry out a septotomy and then cannulate the bile duct from there. It's better to use an Erlangen type papillotome. I do not normally stock that, and if I have to do a septotomy, I just do it with a short-nosed sphincterotome. Again, I wouldn't recommend this procedure to some of our younger, the trainee ERCPs, because it is again something which there's quite a potential for causing damage. Now, guide wires. Guide wires are terribly important because to achieve cannulation or to achieve access to any duct, you need a guide wire, and to maintain that access, you need a guide wire in position to maintain that duct. And guide wires are used for cannulating biliary, pancreatic, cystic, or intrahepatic ducts. And even if you want to gain selective cannulation of right and left hepatic ducts, you need good guide wires and good guide wire handling technique. It is used for antegrade passage of accessories during standard procedure, or even when you fail your standard procedure and you do a combined or rendezvous procedure with your radiologist, you would need a guide wire access. So guide wires are extremely important. And over the period of time, the last 30 years that I've been working doing ERCP, they have undergone quite a major development. They are useful for going through strictures, getting cytology samples and stent placements. So guide wire are important, very important accessories. Various types of guide wire. This is one of the zebra or jaguar. Some of them have got an angle tip. This is quite useful if you want to get selective, get into a particular duct or a straight tip, which is just for going through normal strictures or just normal ducts. Different types of guide wires are used for various indications. Gaining access through tight stricture in biliary pancreatic ducts can be achieved if you use slippery or hydrophilic guide wires. My favorite in difficult strictures is a guide wire called Delta wire by Cook, and I think that is by far the best that I've used so far. Some of the other guide wires that you use for advancing biliary stents or even esophageal stents need to be stiffer because they need more body to maintain the tautness that you need to advance various accessories. So you have to be selective in what type of guide wire you pick. And obviously, as I mentioned, you need very good, well-coordinated assistance, because when you are advancing any accessories like stents over the guide wire, it has to be kept nice and taut. So your assistant should keep enough tension to keep it nice and taut, but not over not be overzealous that he pull the guide wire out for you. So it has to be an optimum level of tension on the wire. The one that we usually use for all practical purposes is the VisiGlide, which, I mean, there are lots of choices which are around, but I prefer the VisiGlide for my the first choice. If that fails, then we use we have the option of using Terumo wires, which are again coiled wires with Teflon coating, very slippery, very nice, good, with various type of angulations. And if all else fails, or sometime if it's my favorite one is the Delta wire. Most of these, you get all sorts of different, companies produce different types of, they all claim that they are great, but generally what I would recommend is that you should get familiar with one or two and just use those as your favorites, because rather than try out different wires when you are stuck, might not always be the best solution. So it's always best to use the one that you are familiar with and you are good at using them. One of the other advantages of Teflon coating is that it acts as an insulator during sphincterotomy, because in the past, as I mentioned, the guide wires were not insulated and we had to take the wire out for carrying out sphincterotomies. But nowadays, you don't have to do that, except for the Delta wire, in which case you have to take the wire out. So there's quite a lot of choice in the wires, whether they are angled, straight, or J-shaped. And again, depending on the indication that you want to use it for, there are the monofilament wires, which are the stiffer wires, which use for stent passage, and the coiled and coated sheath wire, which are more pliable, they are more slippery, and they are used for difficult strictures and selective cannulation. The diameter of, it's important to know that what type of diameter you are using and what type of length you are using. The standard diameter that we use is 0.025 to 0.035. I tend to use 0.025 mainly. You can use even finer wires for pancreatic duct cannulation or minor papillary cannulation. The length of the wires vary from 250 to 480 centimeters. And the reason for that is that if you are used to using short wires, which we exclusively use short wires in our department, then you use the 260 centimeters. Whereas if you are using longer wires, then they come in for 80 centimeter lengths. With the shorter wire, all your accessory are also have to be short wire compliant, because all the stents that we use, the synchrotons that we use, are short wire compliant. Because if you got stents which are compliant with long wires, then you can't. Now, maintaining wire position is very essential, because sometimes if after a difficult cannulation, you achieve that and you are about to perform any therapeutic procedure, the wire slips out, then that's a disaster. So you need good assistants who would do that. To achieve that, nowadays there is continuous marking for visual endoscopic measuring of movement detection, like the tiger patterns or the zebra stripes, or markings which to tell you about the various how many centimeters in. The other device that we tend to use very commonly nowadays is a lockable device, which is something like this, in which you pass the wire under there and then pass it around and get it stuck in there. So you can use 2 or 3 wires at the same time, especially if you are doing selective cannulation of the right, left hepatic ducts, or if you've got a pancreatic duct cannulation already with the wire, and especially in a difficult cannulation, you can leave the pancreatic duct wire in and lock it there. And then you can use your own CBD guide wire again. So this is quite useful tool. From various angles you can see it goes from there and you can stick them there. It comes in different makes. This is from, I think, Boston or another Coke. Stents. There are, you have a variety of different types of stents. They are either plastic, metal, and the stents are used for draining obstructed bile ducts or pancreatic ducts, for ductal leakage, for traversing strictures, for stones that cannot be extracted. You leave a stent in to maintain bile flow and keep draining the ducts. So they have got a wide indication. And I think we are running a bit short on time, so I'll just quickly go through it. They come in various shapes, various types. This is the standard Amsterdam or the cotton Ewing or cotton HyberX stent. This is the single pigtail, usually used for pancreatic stenting. This is again the straight Amsterdam type stent, a double pigtail, mostly used in stone disease. When you've done a sphincterotomy, you want to leave a stent in for drainage. You leave a pigtail stent. The idea is that when it pigtails inside the duct, it prevents the stone from impacting down. The lower pigtail prevents it from migrating inside the duct. They are made of usually a very sort of polythene or Teflon material, and the diameter ranges from, for pancreatic stents, especially from 5 French to, for biliary stents, 12 French, the plastic ones. And the length can range from 1 to 18 centimeters. 18 centimeters very rarely used in some of the higher strictures. For a stent, you need the standard therapeutic Ercp scope with a 4.2 millimeter, because you have to use the stent deployment tube or the guiding catheter. So the double pigtail, as I mentioned, prevents proximal and distal migration, and they also tend to prevent. This is the stent insertion assembly. This is the one by Cook, which I've always used. It all comes pre-assembled. It's a one-action stent introducing system, or OASIS. That's the guiding catheter. That's the actual stent and the guide wire. Then there's a pusher tube behind it. So the purple one is a pusher tube. And there's a guide wire inside those. That's the OASIS assembly. That's the guiding catheter, the stent, and the pusher tube. And when you are past the top end of the stent is above the stricture, then you unscrew this, the pusher tube from the assembly, and it pushes the stent further up. Brush cytology, very important when you are dealing with strictures to take samples from it. So you need to find out if the stricture is malignant or benign. So you use a device called a cytology brush, which is used over a guide wire, and it's got this brush-like structure there. You rub it several times. You rub it well inside the stricture, so that you get cytology samples for it. And if you got a good cytologist, that is an actual picture of the brush cytology. And this is the handle with which your assistant moves it up and down. The guide wire comes out of the side. And at the end, when you've taken all your samples, you cut off the top end and put it in one of the special solutions that you get. We use a cytospin solution. Right, some more toys there. Now, sometimes when you've got a tight stricture and you can't pass a stent straight through it, then we use a special biliary dilatation catheter. It's similar to a CRE balloon, but much finer, and it's very slippery as well. So you can push it through the tight strictures and inflate the balloon. It's called a hurricane catheter by Boston Scientific. Very useful in difficult strictures. These are dimensions. This is the diameter, this is the length of the balloon, and you can use a standard inflating device for it. This is an actual picture of your hurricane balloon, which I find very useful. And importantly, in the past, one of my favorite dilator was a Sohindra's dilator, which is a very graduated bougie type dilator, very useful, but at times very difficult to um, um, uh, pass in tight stricture. So in that case, I then use hurricane balloon. But for all standard purposes, Sohindra's dilator used to be quite useful. Just some pictures of some stents. Again, pancreatic duct stents are important. You use them in special circumstances, especially if you had repeated cannulation of the pancreatic duct to prevent pancreatitis. It's always good to prophylactically insert a stent in and then take it out after a few days. Nowadays, we are using biodegradable pancreatic stents, in which case, this is one of the typical pancreatic stents, in which case you don't have to go and take them out, they just get absorbed. Those are made of stricture suture material, so they come in handy. Sorry, I have to rush through because I've got a bit of a ground to cover. Now, another important type of stent is the self-expanding metal stent, which we use quite a lot for various indications. A lot of them are used in malignant pathology and sometimes in benign conditions as well. There are various types of self-expanding stents. This is one of the fully covered ones. The metal alloy that is used for making the wire mesh is called nitinol. It is supposed to have memory in it because when the stents are deployed, they are in a squashed form. And when we release them, they go back to their memory in which they were made. So they expand. The diameter of the stent that it varies from 6 to 10 millimeter, but the one that we use in biliary tree are the 10 millimeter, and the length ranges from 4 to 12 centimeter. There are 3 different types: the uncovered, which are used in inoperable conditions where the stent has to be left there permanently, the partially covered, which can be taken out, and the fully covered ones, which are quite useful. They can be removed anytime without any problem because there is no tissue ingrowth in them. Now, I'm not sure whether I can play this because one of our stent was not deployed, so I did use a video to show. I saved it for this thing, so I just did it in our. This is how you deploy a stent. The outer sheath is withdrawn by your assistant, and it comes out. So that's 700 pound out for you. This is a fully covered stent. Again, another one, different shape. If you look at those little loops, they're meant to move for when you want to remove the stent. You can grab hold of them with a grasping forceps and pull them out. Alternatively, you can grasp one of the loops inside, and it will fold inside like a sock, and you can pull that out as well. That's that's less traumatic, but equally, this is equally safe and easy. Partially covered stent, you can see the covering is up to here. The partially covered is there to maintain so that it doesn't get migrated, because the fully covered stent have got a potential for migration. This is a standard uncovered stent. And this is how an assembly of, what the stents are, assembly is made of. That's the deployment exterior to everything, yeah. Stent extraction. For removal of stent, once the you can, use various instruments. They can be removed with help of grasping forceps. They can be removed with help of polypectomy snares. There's a special device called the Sohindra stent extractor. This is very useful in the sense that it screws into you can see the groove screw. It screws into the plastic stent, and you can extract it. You can do that over a guide wire, and that means that you don't lose your position when you take the stent out. You can leave the guide wire in, and it will allow another stent to be inserted. Sohindra stent extractor can also be put to good use in very tight stricture where you can't use any dilator. This screws into the stricture, and I've used it in some of the very difficult strictures, and it works very well to open up a channel. This is a grasping forceps that we use for grabbing the stent, and a snare. Stone extraction devices, how do we do that? We can use a stone extracting balloon, and you pass the balloon catheter over a wire above the stone and inflate the balloon. Comes in various sizes like 8.5 millimeter, 12 millimeter, 15 millimeter. So depending on the stone size, you use different types of balloon, and depending on the size of your bile duct and the sphincterotomy that you've performed. So another picture of your balloon extracting catheter. One of the important maneuvers that you do with a balloon is a balloon trawl or a balloon sweep. After you supposedly cleared a bile duct of stones, it's always a good idea to go up to the top of the bile duct, inflate your balloon, inject contrast as you come out, and make sure that there are no stones or any thing left inside the bile duct. So that's called a balloon trawl. Some of the balloons also have a injection port distal to the balloon, in which case you can tell if there's any stone under the balloon. Metal wire baskets are most commonly used device for stone extraction. I use them for awkward shaped stones because sometimes if they are oblong or rectangular, then they are difficult to extract with balloon as they get stuck crosswise. So I use metal wire baskets, which come in different configuration, and they are quite useful for taking those difficult stones out. They come in various shapes and forms. The only worry with the basket is that sometimes if the stone is big and it gets impacted and you can't get the stone out of the basket and you can't pull the basket with the stone impacted in it out of the bile duct, then you are stuck. And that means that the patient may have the basket sticking out of his mouth and might require surgery. So in that case, it is like an emergency. We use a rescue lithotripter, in which case you cut the wires from the handle of the basket, take your scope and everything out, and then attach the wire through this device, and the wire come through here. You roll them on there, you hold the hand there, and then you start rotating this, and it crushes basically breaks the basket rather than the stone, because the baskets are not very strong. So once the basket is broken, you just take the basket out. So you are not left in an embarrassing situation. Some of the baskets are meant for lithotripsy. These are tough, they are made of tough material with a tough sort of the metal ball or a chip at the end. And you can use them for catching bigger stones and using this device to crush the stone. There's a limit to the size of the stone that you can crush with this. Some stones are too big to come out, in which case you can use a lithotripter basket to crush the stone and take them out. You can perform a sphincteroplasty using Cre balloon. They range from various sizes from 8 millimeter up to 21 millimeter. I tend to stick to usually 15 millimeter, which is safe because the risk of bleeding goes up the bigger balloon that you use. And ultimately, if you can't take them out with this, is either surgery or spyglass. Cre balloon, I'm sure you all have seen it. That's how it looks like. That's the inflator device that's used for Cre balloon, and another shot of the Cre balloon with its own integral guide wire. Now, on several occasions, I've seen quite massive bleeding after a Cre sphincteroplasty, and it just comes from all over the place. And at times, there's not much you can do. So the only thing that you can do is put a fully covered self-expanding metal stent in there, and that's because of the tamponade stop the bleeding. Last but not the least is the spyglass, which again is a very useful device for actually visualizing the common bile duct. Useful for big stones where you can crush it by electrohydraulic lithotripsy, or for visualizing cholangiocarcinoma and taking biopsies. Now, in conclusion, ERCP is a very commonly performed procedure worldwide. There's a wide range of accessories available for successful and safe performance of ERCP. Endoscopists who are performing ERCP should be well versed with various types of accessories and keep themselves up to date with newer equipment. Now, one thing which I always tell my juniors is that over the last 30 years, with development in endoscopies and the accessories, the incidence of complication has come down quite dramatically with all other endoscopic procedure. With ERCP, the risk of complication over the last 30 years has remained static. So please treat it with respect. Thank you very much for your attention.
Thank you, Waqar bhai. This is Khalid from Orlando.
Hello.
Thank you so much.
Nice to see you.
Good to see you too. Thank you for the excellent presentation. It is not really easy to cover every accessory in one talk. And the beauty of these talks is like we're going to have a lot of presentations. There's going to be some repetitions, and every talk would cover some sort of accessories. So I really appreciate that, and that you did really a great job. A few things for the attendees, or a few things for all of us, just a reminder is like whatever accessory, whatever scope you use, you really, really need to know how it works. What are the characteristics, how it needs to go into the bile duct or the pancreatic duct, what your intention is, what you intend to use it for, all that has to be really, really clear before you use accessory. Don't think that you're just going to get in and just put that in. It's not works. It doesn't work that way. And it's usually that's when you run into trouble. Other important thing is for ERCP, it's always about the position. Get into the best position before you touch the papilla. Majority of the time it's going to be short position, but that doesn't always work. Sometimes it's a semi-long position, sometimes it's a long position. For minor papilla, usually it's a semi-long. But I agree with Waqar bhai that majority of the time, the best position is the short position. But if that's not the best, what's working for you for that particular patient, try a semi-long, try a long position. The whole purpose is don't touch the papilla until you think you have attained the best position. And even before you touch the papilla, I usually tell all my trainees, talk to the papilla. You keep talking to the papilla, eventually it will start talking back. And Waqar bhai, I really love his usually comments. He usually says, if agar tum thappad maroge papilla ko, to wo tumhe do thappad marega. So don't really try to beat up on the papilla. Okay, so just be very gentle. I mentioned about the repetitions, that all will happen. And I think unless there is any comment from Saad bhai or Nadeem, then I'll conclude after that. Saad bhai?
Thank you, Khalid. Thank you, Waqar. Excellent, comprehensive coverage of this very important topic. I think I totally agree with what Khalid said. Just a couple of points that I would like to add is that if you're going to embark upon doing ERCPs, the accessories that Waqar is used to or Khalid is used to, or maybe in some sense, some of those who do a lot of cases even in Pakistan. But generally, when you're setting up something and you want to do, and you're not very experienced, then I think it's very important to have all the important tools that are needed before you jump into doing these things. There is a tendency of having just one sphincterotome and a wire, and okay, fine, you've got a stent, and if something happens to that sphincterotome, you've already cannulated the patient, you're already halfway. So there is no point doing these procedures without having backups. You don't have to have fancy accessories. We, unlike our colleagues elsewhere in the world, we use very simple sphincterotome. I don't really care what is sphincterotome. If it's a new one, I'm really happy. But generally, if you know how to do it, and if you're position, this is what we teach in our course as well. If you have the right position, then even with whatever tool you have, you should be able to get in. One thing that Waqar mentioned about sphincterotome is about the cannulas. I think cannulas sometimes are useful when you're doing pancreatic therapy. And that is the only role, like Waqar said, for general I think most people in the world would start with sphincterotome, like Dr. Waqar said. Occasionally, I think the only use left for cannulas, to be honest, in our practice, and I'm sure Waqar also does that, is when you want to really cannulate pancreatic duct, and sometimes you can't get in, and a small tip can be used. Guide wire, again, I think it's very important to have good guide wires. If you're going to be doing difficult cases, then it's important to have different type of guide wires with you. You have to invest in these accessories if you really want to do these procedures. This procedure, which is normally appears very simple when Khalid and Waqar are doing, and if you leave it halfway, and this is what we have seen sometimes, where you've actually not been able to do the procedure because you did not have the right accessory, you cannulated, you injected, and you now have created basically a bag of abscess in the CBD, and end of the day, that patient really goes down really quickly. So I think that's important. The rest of the things Waqar has already covered mostly. Start with basic stent size and everything else. I think it's important to have the common ones with you at least. Guide wires, I think, is very important. Balloons, again, balloon occlusion cholangiogram, like Waqar said, can't emphasize more. I have seen in my practice from people who are experienced and who think they have removed the duct stones completely. Occlusion cholangiogram not done, and the stone, we don't know if the gallbladder is there. The stone migrates later on. The patient comes back, starts complaining because you have no evidence. So I think occlusion cholangiogram, other than just confirming that you've cleared the duct, also gives you that protection in case the gallbladder is still there and another stone manages to pass down. At least you can say that you've cleared the duct. Needle knife was something that I wanted to touch on. I think that equipment is very important. The technique is important, but I think for those who have not done it, it's best done under supervision initially, and then following that, once you've understood and once there was a question, and I'll just touch that just in a minute. And the question was, with if you can't get into the pancreatic duct, with double wide technique that had been tried, and they think that double wide technique doesn't work. I personally feel double wide technique works most of the time when I use it, and I think it's a very good technique. And for those who are finding it difficult, they need to go and watch videos, or ask somebody who's doing them to explain it to them. Other than that, just put a pancreatic stent, come back another time if you're tired, because there's no point doing procedure when you're tired. Or once you put a pancreatic stent, you do a needle knife or try and cannulate again. So that would be that. And I think there are otherwise, Waqar, once again, thank you very much for taking time out on a Sunday and covering up and discussing the different accessories that you use and that are available. Thank you.
Yeah. So thank you. Nadeem, you have any comment? Nadeem Tahami, are you still with us?
No comment. No, thank you very much.
Okay. So
yes, no comments. Thank you.
Okay. So I think again, I want to stress that we can talk, literally give a whole lecture on a double wide technique if we intend to do that. But these
Absolutely.
things and some questions are there about the trapezoid basket, about how to stone, how to do this. So all those are you cannot cover all those in one presentation. So all those will be covered eventually. There will be a stone talk, there will be a cannulation talk, and there are so many presentations. So I think some of those questions will be answered better in those presentations. So last comment, next Sunday, I will be talking about the EUS accessories, and it's the same time, 6 p.m. Pakistan time, and 9 a.m. for me here. So with that, I thank you, Waqar Bhai, thank you, Saad Bhai, and we'll, until we meet next time. And thank you, Wilson Cook, for their support always.
Khalid, thanks to all those who actually attended the thing and have sent very nice, positive messages to us for all the effort that is being made. We are very grateful for all of you, because obviously if you weren't here, we wouldn't be talking. So thanks to all those who attended, and we look forward to seeing you again next Sunday. Thank you.
Thank you.
Okay. Thank you so much. Assalamu alaikum, everybody.